comparison with historical controls. If you look at MACE, propensity matched at 30 days, there was no difference. But in those patients who presented with cardiogenic shock or cardiac arrest, there was a significant difference in MACE, including mortality, in the group who'd had post-conditioning, 27.8 versus 42.7 in those between 2013 2016. So this brings me to really one of my concluding slides, and this is from a study on the Duke database, and actually the North Carolina race database, but Dr. Koshar was a fellow at Duke at the time that we did this study in conjunction with collaborators at that institution. And this illustrates the in-hospital unadjusted mortality rates stratified by the presence of cardiogenic shock and cardiac arrest at presentation. And this is for the entire state of North Carolina. And what you can see is if you have a STEMI and no cardiogenic shock, no cardiac arrest, mortality 2.8%. That's what it was in the Condi-Eric trial. And so I can understand why additional salvage is going to have no clinical impact. What is interesting is the group that had cardiogenic shock but no cardiac arrest. And if you look at this group, they had a 23.4% mortality. In those with cardiogenic shock and cardiac arrest, I think the mortality is so high, I'm not quite sure what we can do to influence it. And if they had no cardiogenic shock but cardiac arrest, 17.4% mortality, but that may be neurological. But what I think is important is that we do a trial in this group of patients, and right now this trial is being discussed with Dr. Thiele in Leipzig, Germany. Whether we'll be able to do the trial or get the funding remains to be seen. I think everything is a little on hold right now in the COVID era. But before we put cardioprotection to rest, I think we need to look at this group of patients when I believe there is a real potential for a therapeutic benefit. So it's been a long and bumpy road. Have we come to the end? I don't think so, not quite. But it has been an interesting but discouraging road to travel. And my final slide is written by Dr. Hoysh and myself immediately after the Condi-Eric trial was presented and published at ESC in 2019. And we state, is cardioprotection salvageable? And our statement is that if you look at the real world of developed countries and even more so in developing countries, the clinical outcomes of acute myocardial infarction are not as good as in the aforementioned trials. In Condi-Eric, mortality was 2.8%. There's still an unmet medical need for adjunct cardioprotection beyond rapid reperfusion, particularly in patients with higher killer classes and less than optimal reperfusion. In consequence, there is also an unmet need to develop better cardioprotective strategies, and we would advocate that to give up on cardioprotection at this point is premature. I think we need one other definitive trial in higher risk patients, whether that be done in the developing world or the developed world or wherever. I don't think that's what's important. I think what is important is there's an unmet need out there. There's a group of people who do not have a 2.8% mortality. The mortality may be 4 or 5 times higher. And before we abandon ischemic preconditioning as a cardioprotective approach, I think we need one more trial. I just hope we can ultimately get it funded. Thank you for your attention.
Thanks, Dr. Gersh. Dr. Gersh hasn't logged on yet, so anybody in the panel would like to make a comment on the topic that was just discussed.
Yep, Tom, I think this is a very, very difficult area. So I don't know, I discussed with you some work with the metformin data in the membrane transition pore. in patients with diabetes. And we are running this interesting pre-diabetic group of patients on metformin, and to see the outcomes at 5 years in terms of atherosclerotic progression and event rates in about 5,000 patients. And then, it comes to the point that a drug sometimes may be useful, but it may be useful just a bit. And to show, as Dr. Gersh said, when the mortality is low in 2 low-risk patients may not be useful, and in 2 bad patients it may not be good too. So we need to correctly pick that group of patients. I'm also not sure whether we should give it earlier, because sometimes we treat reperfusion after the event. I'm not sure it's too late, because whether the drug will work at all. If we have it pre on it, and that's difficult to predict who will get that. So say a drug like, say, metformin, you're already on the patient on metformin, and we see what happens during, say, a shock scenario. Maybe we could possibly see a benefit there or not. But I think the important thing is many of the drugs are not working because it's either too late to give it when the infarct starts, because to get to the cellular level to stop the reperfusion injury, it may be too late to give. I'm not sure what others think about this.
Thanks, Ajit. Yeah, metformin seems to be a good candidate drug to try out. Yeah. Any comments from any of the others in the panel?
I agree with Ajit. I think the new kid on the block is the SGLT2 inhibitor. And I think if you use medications which kind of are still at the drawing board, which work with myocardial energetics, it's going to be the next frontier, I think, because in some ways these medications are helpful in heart failure and probably also in kind of myocardial stunning, myocardial hibernation, and maybe with preconditioning. I think SGLT2 inhibitors may be better than metformin, but they're expensive.
SGLT2 inhibitors is a promising drug, but I think one trial is also underway now, IMPACT MI on empagliflozin. So we may know the results of that, but this is an interesting area. It's a difficult area, but this ischemic preconditioning remote one, I think at least one thing that we can try easily in India. It doesn't require much of an infrastructure. So that is one thing that we can certainly try in India. In a higher risk patient, so that if at all there are benefits, we can see them.
Thanks, Shireesh. And I think we need to move on to the next talk. This is by Dr. Raghavendra Baliga, who will discuss cardiogenic shock. I think this is something that would interest everybody, those who manage MI, whether in the cath lab or in using thrombolytic. Raghavendra Baliga is director and professor at the Ohio State University, a prolific writer with many textbooks. Baliga.
I'd like to start off my talk on cardiogenic shock by thanking the course directors, Dr. Thomas Alexander, Dr. Ajit Mulasari, and Dr. Sathe for inviting me to talk today. I do admire their relentless pursuit of management of STEMI in the Indian subcontinent, and they continue to strive with this effort even through the pandemic. My disclosures, I've edited atlases on heart failure and interventional cardiology, and have some of the data in this talk is derived from these books and from 2 guidelines, white papers which we wrote for Global Heart, where in the STEMI white paper we had Dr. Thomas Alexander and Dr. Mulasari as co-authors. I'd like to start off by the term shock. It actually originated from an inappropriate English translation of the word CHOC, which is chalk, which was used by a French army surgeon, Henri-François Ladran, to describe the collapse of vital functions culminating in death that he observed in soldiers who had been struck by missiles. In the 1800s, John Collins Warren described shock as a momentary pause in the act of death. Cardiogenic shock is a low output state stemming from primary cardiac dysfunction, resulting in hypotension and systemic hypoperfusion. This maladaptation is perpetuated by physiologic cycles of inflammation, ischemia, vasoconstriction, and volume overload. The way I remember this is IIVV, that is inflammation, ischemia, vasoconstriction, and volume overload. As I said, this is a vicious progressive cycle of inflammation, ischemia, vasoconstriction, and volume overload. The manifestations of cardiogenic shock are a systolic blood pressure less than 90, a cardiac index less than 2.2, a cardiac power output of less than 0.6 watts, and lactic acidosis. And this results in sympathetic stimulation, severe vasoconstriction, activation of the neurohormonal system, hypoxemia, microcirculatory dysfunction, pulmonary edema, systemic inflammatory response syndrome. So all this comes to a head, resulting in multi-organ dysfunction and mortality. The mortality in the shock-associated acute myocardial infarction is unchanged in the last 20 years. The number of cases of cardiogenic shock in the US, as you see from the left panel, keeps rising every year, and the mortality continues to be high, around 50%. So, as you can see, there are more and more people getting cardiogenic shock, and this is the 50. So the pie is getting bigger, and the 50% of the pie means more people are dying. And this slide, which I borrowed from the Detroit Shock Initiative, is half the group are dead within 10 hours. And in this data, the overall mortality was as high as 86%. So what are the stages of shock? And the SKY, the interventional group, classified into stages A, B, C, D, and E. A is at risk. There's neither hypotension nor hypoperfusion. Stage P is just when it's beginning. There's tachycardia, hypotension without hypoperfusion. Stage C is classic, which we see as cardiologists, hypoperfusion without deterioration. Stage D is without refractory shock, and stage E is extremis, that they are in refractory shock. One thing I'd like to add that this classification works really well for acute myocardial infarction, cardiogenic shock associated acute myocardial infarction. But there may be patients like in heart failure who may be in pre-shock, in which compensatory vasoconstriction may maintain near normal systolic blood pressure despite malperfusion, sometimes falsely reassuring physicians. Although it comprises only 5.2% of the shock trial registry, the mortality in this group was as high as 43%. As you see, the in-hospital mortality and the ICU mortality is very, very high in each stage, stage A, stage B, stage C, stage D, and E of cardiogenic shock. The treatment objectives of shock are first to make a timely diagnosis, that is a CPO less than 0.6 watts, a cardiac index less than 2.2, and increased lactate concentration. And this slide shows that there is a plethora of manifestations: LV dominant cardiogenic shock, RV dominant cardiogenic shock, biventricular cardiogenic shock. And the approach varies and requires assessment of every patient with cardiogenic shock. And one of the key takeaways is that early initiation of support, especially with Impella, has shown to improve survival and reduce mortality. And in fact, The longer you wait, higher the mortality. So the concept of door to support time, like the door to needle time, is a really important consideration in the management of cardiogenic shock. And this slide shows the same thing, but it shows survival in the three terciles depending on time to onset of cardiogenic shock. Another very important takeaway is fewer inotropes are better. So by the time the patient's on 3 to 4 inotropes, the mortality is as high as 36 to 26%. And some have argued that 0 inotropes is better. And this may just reflect the severity of the shock, not actually the utility of inotropes. But however, there is data to support from 2 small trials that norepinephrine is the preferred first-line agent, and a retrospective analysis suggests similar outcomes with dobutamine and milrinone. So one would argue that if one is putting together a cardiogenic shock program, every ambulance should have a norepinephrine for now till we get more data as the preferred first-line agent in the management of cardiogenic shock. There is data from the Detroit Cardiogenic Shock Initiative that using an impeller early in the course will reduce the need for inotropes and pressors. In fact, the Detroit Cardiogenic Shock Initiative has now been renamed the National Cardiogenic Shock Initiative, and the goal is to put the support, that is the impeller, before the PCI in an acute STEMI. And the aim of this initiative is to reduce the door to support time to less than 90 minutes, establish STEMI 3 flow, put a right heart catheter or Swan-Ganz in, wean off vasopressors and inotropes, maintain CPO, which is cardiac power output. Cardiac power output is a product of mean arterial pressure and cardiac output divided by 451, and improve survival to discharge. And the goal is to improve survival to discharge to greater than 80% based on preliminary data. In fact, Bill O'Neill, who's the lead on this, had a letter in JACC in 2017 where they looked at a small subset where they used impeller, and they reported in this very small subset that of 15 patients a survival of 80%. And this letter in JACC intervention was in 2017. They followed up in 2019 in the Journal of Catheter Cardiovascular Intervention, where they looked at a much bigger cohort of 171 patients. And again, they found that the survival is as high as 74% of patients who had started early on support, particularly with impeller in this cohort. So they argued that time is the essence, door to support time of 60 minutes, aggressive reduction in the use of inotropes and vasopressive medications post-procedure, and to make sure there's a right heart catheter there to manage invasive hemodynamics. Going to the big picture, the establishment of a regional system for cardiogenic shock is something which has been championed to improve survival. And just like STEMI India has done the hub and spoke model for management of STEMI, the cardiogenic shock is kind of based on a similar template. And again, the principles are the same. The principle is to reduce the door to support time and transfer them early to a level 1 shock center. In fact, I would argue that the STEMI India leaders can easily piggyback this model to their current model, because they already have a lot of the infrastructure already in place. And this involves identification of the shock state, stabilization, and transfer to a level 1 shock center where they have their first, there is support, and then there is coronary revascularization, and then a right heart catheter to manage hemodynamics. So how are the levels decided? Level 1 is a dedicated cardiac shock center. Level 2 is a STEMI receiving and PCI capable hospital without advanced MCS. And level 3 is a non-PCI capable hospital. But it's really important that the system has, at the level 1 center, has the whole team of physicians, cardiologists, cardiac surgeons, ECMO, palliative doctors, nephrologists, infectious disease specialists, because this is a team effort. And at any time in the management of cardiogenic shock, one has to go back and forth between choices between recovery and palliation. But it is possible, given that STEMI India already has this infrastructure about early transfer from a spoke hospital to a hub hospital. And briefly, there are different kinds of support systems for left ventricular and right ventricular support. And the two workhorses are IABP and Impella. No, not Impella 2.5, Impella 5. Impella 2.5 is like IABP. And the advantages of Impella 2.5 or Impella CP is the flow is 2.5 to 5.5 liters. It's an actual flow pump, and there's a lot of LV unloading, increased cardiac power, and improves coronary reperfusion. And since the Impella's balloons is across the aortic valve, it's contraindicated in mechanical aortic valve and in LV thrombus. We have had patients with both VA ECMO and Impella, because in VA ECMO, sometimes they require afterload reduction. But this is kind of, in a nutshell, the options for management of. Then lastly, I want to talk about opportunities. The STEMI India is well positioned to do this, and there are clinical gaps in knowledge both at diagnosis, tailored therapeutics, which is the best MCS, mechanical circulatory support, which is best for revascularization, which is the best vasopressor, which are the best antithrombotics. And there are clinical gaps in care delivery models. Is it the hub and spoke model? And then there are gaps in knowledge in palliative care. So with all this, there's a great opportunity in management of cardiogenic shock, and I think STEMI India is well positioned to do it. Hats off to the leader of STEMI India, Dr. Thomas Alexander, Dr. Ajit Mulasari. And I'd like to thank you all, the course directors, for giving me this opportunity to talk. Thank you.
Thanks, Raghavan. I think that was a great talk. I think you've thrown out a lot of questions and suggestions for all of us to think about. But having said that, I think we need to look at cost-effective ways of getting these patients early and managing them. Impella, as you know, is such an expensive device in our country. And I mean, as a go-to device, clearly that would have a very, very limited option in our country. But having said that, there are many, many more interventions that would certainly help in preempting or managing patients with shock. Baliga, your comments on what you think is feasible in our country?
Yeah, so I wasn't aware about the pricing, but yeah, it has to be cost effective, Thomas. I agree. I think maybe, even a balloon pump. I know, balloon pump, early balloon pump may be the way to do it, because as soon as the patient comes to the ER, sometimes, I mean, when we were fellows, we used to put the balloon pump in, by the bedside. So you don't even need to wait for going to the cath lab, In fact, in this Detroit Shock Initiative, they wouldn't enroll anyone who was already in a balloon pump because it muddies the data with the Impella. But I have a feeling that something is better than nothing from a support perspective, and maybe just even, and we know from our experience, so many people we have used balloon pump as a kind of a rescue, and maybe putting a balloon pump right off the bat, and a right heart cath by the bedside even before the patient goes to the cath lab for PCI is maybe an option. I don't know what thoughts of you all who are in the front line, down in India, what your thoughts are on that.
Comments from anybody else on the panel?
Yeah, I think although SHOCK 2 trial tells us that IABP is not really useful, I think early initiation of IABP will play some role, at least a key role. And that's the only thing that is available out of all circulatory support devices in India. The others are really very expensive. So across India, I think it's IABP. And if we really use it judicially and use it early, it may make a difference.
I think if we could get a subset of patients from the spokes who are thrombolized, put in IABP and then transport them to the hubs for pharmaco-invasive, we might well have a great model in managing early shock and preventing mortality. Thanks, Baliga, for these suggestions. I think we need to work together to see where we can implement it and take it forward. Any other comments from anybody else in the panel? Okay, we go on to the next talk. Again, this is Bernard Gersh again, talking on the changing history of ventricular remodeling after STEMI and the role of AC inhibitors and ARBs. Dr. Bernard Gersh.
I'm Bernard Gersh, and my next topic is the role of, or the changing nature of ventricular remodeling after myocardial infarction, and is there still a role for ACE inhibitors and AR blockers? This is from a paper published with the statistician, Dr. Stuart Pocock, and what the question discussed was, should evidence come with an expiration date? This is from editorial by Green, and then Pocock and I really talked about the need for new trials of old therapies. The trials of ACE inhibitors are now well over 20 years old. And he coined the term, should there be a statute of limitations for evidence? And the examples we gave were beta blockers after MI, which I'll talk about next, ACE inhibitors, ARB after acute coronary syndromes. We talked about trials of treatment withdrawal. What happens when you've given a drug for 20 years and the patient is older and renal function is declined? Should we do those trials? Can we afford those trials? And there's some questions about the ICD trials that are not relevant to this talk today. So when do we start or stop ACE ARB in patients with acute coronary syndromes and nearly normal LV function? The randomized trials are helpful, but they do not provide all the answers. To some extent, we're dealing with old data which may or may not be applicable to contemporary practice. So let's review the old data. The principle for angiotensin converting enzyme inhibition was to prevent remodeling. We had several trials in patients with anterior MI, transient heart failure, impaired LV function. All of these trials were positive, and the duration of therapy was indefinite. This is called the selective approach. In Europe, there was a more inclusive approach, and that was give ACE inhibitors to all patients and then reassess at 4 to 6 weeks if they have LV dysfunction or any other indications for ACE inhibitors. Both sets of trials were positive, and I think it is really a matter of opinion, and that is on this side of the Atlantic, we tended to be more selective as opposed to inclusive, but both approaches were perfectly justified based upon the trial data that we have. So these are the selective trials, a number follow-up from 15 to 42 years, save air, trace spile. What they showed was in terms of lives saved per 1,000 patients, a significant number was saved, the duration of therapy was indefinite. And then with the inclusive trials, where everybody got the drug and then it was only continued in those at higher risk, clearly the number of lives saved was less because we're dealing with a short period, a much shorter period of therapy and a lower risk group overall. So the recommendations at that time, and subsequently these have been updated by the ESC guidelines that were published in 2019. ACE inhibitors or ARB are recommended if the patient has other conditions, heart failure, hypertension, or diabetes. What about patients that are considered to be... Unfortunately, I activated Siri on the phone. Do you want to just go back a little bit? 19 in CCS, chronic coronary syndrome, patients at very high risk of cardiovascular don't have diabetes, they have normal LV function. Are ACE inhibitors obligatory? No, but they should be considered, and I would agree with that. 2A. So then, several years ago, when the trials showed a 23% reduction in myocardial infarction, the SAVE trial of Dr. Pfeffer, which I worked on, showed a 25% reduction in myocardial infarction. Now, but then we had to go back and look and talk to what the basic scientists had been telling us all along, and that is the links between angiotensin II and atherosclerosis. Angiotensin II stimulates vascular smooth, all detrimental, and it's prothrombotic. So as the basic scientists said, I'm not surprised, we're not surprised at all if, in fact, inhibiting the angiotensin converting enzyme or the whole cells are now not focused on LV dysfunction, but trials that really looked at the effect of ACE inhibitors in vascular disease and cardiovascular death. And two of them, one of them showed a very high improvement in reduction in risk. The Europa, not quite statistically significant, but a strong trend towards benefit of cardiovascular death in people with vascular disease. Overall, hazard ratio is significant. So this led to a tremendous amount of bisoprolol that we used, active. Yes, it was. Blood pressure reduction was adequate. It reduced diabetes and heart failure hospitalization. Was the dose we used too low? No, it was a dose that had been shown in other trials, showed a benefit. So there's no reason why in these people with vascular disease, there should be class effects. And I think the effect and the explanation was this. Although these patients all had pretty normal LV population, much, much lower risk. All of them had had ejection fractions that were in the normal range. We excluded people with severe vascular disease. And so this analysis shows deaths due to cardiovascular causes, these three trials. And as you can see in PEACE, a much lower rate of death due to cardiovascular causes. And it actually approximates that noted in the so how do we reconcile the results of these trials? Well, ACE and ARB should be considered, I think, considered for all patients with vascular disease. We didn't say in the PEACE trial that it doesn't have to, that it's contrast hypertension or LV dysfunction. They should be routine. And ACE and ARB, the choice can be individualized. We've seen a beneficial effect from both. But as the risk decreases, LV must be very specific. In patients without hypertension, without diabetes, without any form of LV dysfunction, routine use of ACE inhibitors are not mandatory. And we're finding more frequently that we're dealing with patients who are much older and sicker. And how many drugs can they take? And polypharmacy is not a good thing. So I do think that this is the point that we make with system inhibition versus placebo. And what you see is that there is a benefit in terms of all-cause mortality, cardiovascular mortality, MI and stroke, And these are patient angiotensin system inhibitors, not versus placebo, but in patients who have active controls. And what I mean is they're being treated for hypertension, maybe calcium antagonism, that the difference between all-cause mortality, CV mortality, and stroke falls away. So again, just to make the point that the trials which compared these drugs with the placebo were excellent trials for diabetes or hypertension. Some of these patients had hypertension, and if they're being treated for hypertension with other drugs, we do not have to add an ACE inhibitor unless there are other reasons such as systolic dysfunction or heart failure. Now, this is a study of almost 2,000 patients with primary PCI who are very well treated. They all have ACE inhibitors or ARBs, beta blockers, aspirin, statins. How often did we see remodeling? Well, when did it occur? Most of the time it occurred fairly early. In some people it occurred around about 3 months and others a little later. Now this is the pattern we saw. These are the changes in end diastolic volume, difference between the two groups. What about the effect of remodeling after STEMI in the current era? 2018, whatever, 2019. Well, but look at the effect on mortality. None. Heart failure hospitalized, and in those with an ejection fraction of less than 40%, whether they remodeled or didn't remodel, had no effect. So what I've done here is compare the effect of remodeling in the current era, our data, on all-cause mortality, and then I'm going to show you in green the SAVE study. So at all-cause mortality in SAVE, in green, and yellow is remodelers in our study, orange non-remodelers. What you see is a significant difference. 42 months was 20%. The mortality now is 8 or 9%. And the only time we get up to the SAVE mortality is when we get out to 120 months. So we reach after myocardial infarction, the 10-year mortality in people that were in our study is equivalent to the 42-month mortality in the SAVE study. So it really raises a lot of questions, ACE and ARB. We have to individualize and measure the continued benefit against the frequency and tolerance of side effects. And remember, after 10, 20 years, these patients are older, they have declining renal, STEMI changed in the current era. There are 3 clinical scenarios I want to show you. Early reperfusion, patients who for other reasons are already on ACE, ARB, and aldosterone, still frequent. But in the modern era, the adverse impact of mortality on LV function appears to be blunted. Heart failure hospitalizations are still increased in those that remodel. I think the indications for ACE, ARB have changed. We can still give them to prevent heart failure hospitalizations in people that remodel. If they're already on the drugs for good reasons, they should stay on the drugs. Is our recognition that age, renal function, and increasing side effects over time may warrant reassessment. And just because you start a drug 20 years before doesn't mean you have to be in it forever. So one has to.
Thanks, Dr. Gersh. Again, I don't think he's here on the so maybe 1 or 2 comments from those on the panel, and we'll move on to the next talk.
ARNI. So ARNI post-MI versus Ramipril. So that will be interesting to see. I think it is expected next year. So that is a new modern trial, modern medication. It will be
quite agree. Dr. Ramakrishna, you're muted. Yeah. Go ahead.
Now you can hear me?
Yes.
Among ARB and ACE inhibitors, which one you prefer personally?
Maybe enalapril or otherwise it's valsartan that I usually use, but
And now many of us are using RNA, you know.
Yeah, post MI, there is no evidence. So that's what I said, that Paradise MI is the first trial which they are testing, RNA post MI. So once that trial is out, we'll know whether to use RNA post MI.
Okay, I think we've come to the end of this session, and we need to move on to the next session. To those of you who would like to move on to Hall B, let me remind you that the talks on ECG going on in Hall B. Those of you who would like to stay on in Hall A, more of interventional topics coming up. We go on to the next talk. This is by Dr. Venu Menon. Is Director of Coronary Care Unit at the Cleveland Clinic, a good friend of ours, a very keen supporter of STEMI India. Welcome, Venu, to this talk. Venu will talk on support devices.
Great pleasure for me to be part of this virtual conference. I want to thank Tom and Ajit for inviting me to be part of this program. It's always been a favorite time of my year to visit India, and have had that both Ajit and Tom have arranged to have this program virtually. So in the next 15 to 20 minutes, I'm going to talk a little bit about support devices in high-risk STEMI management, which is, we know that early revascularization is the one thing that saves lives when cardiogenic shock complicates acute myocardial infarction. Shown here is the classic slide from the shock trial. However, it is also obvious that the mortality rate with shock, despite revascularization, remains high. And although we've adopted primary PCI strategies around the world, this mortality is. And there's two main reasons for that. One clearly is that patients present late and we're not able to salvage enough myocardium. But the second reason is that in the setting of shock and hemodynamic compromise, end organ injury, either to the brain, the kidney, or the liver, that ends up resulting in mortality. And as a result, we are not able to move the needle in this setting. What has really changed is support the ventricle, and with it comes the promise that end organ injury can be prevented. So that if there is recovery of myocardium, the patient does not have the end organ injury, and therefore acute myocardial infarction has evolved. So when a patient comes with shock and acute myocardial infarction, the first thing to certainly consider before embarking on a very long and costly strategy cannot be helped. These are the moribund patients who are old, in their 80s and 90s, with prior strokes and renal failure. We all know when we see these patients that it's unlikely that we can avoid pursuing the strategies I'm going to talk about in these patients. However, at 3 o'clock in the morning, it's often extremely difficult to make this decision with an acute MI patient whose background is concept of revascularizing and going on with an adjunctive bridge. This bridge is a temporary mechanical support to preserve end organ function and gives us time to look at the response recovers. For those group of patients, we are able to withdraw support and pursue discharge the patient. So we call that a weaning strategy. For those who do not respond, support dependent, we can go with advanced options, which might be a left ventricular assist device as a durable bridge to decision, a bridge to recovery, or a transplant. And so using this strategy, we are all familiar with the intra-aortic balloon pump. This is something that has been available to us since the early 1970s. It's clearly widely available and can be placed at the bedside. There are hardly any complications. Certainly increase urine output and augment contractility by decreasing afterload. And so in the shock trial, all the patients who went for revascularization, up to 90%, had an adjunctive standing trial done by Holger Thiel that has some critique to it. You can see that in patients with shock post-PCI, randomized to intra-aortic balloon pump versus placebo, there is absolutely no win at the end of 1 year in long-term follow-up. And this lack of benefit with an intra-aortic balloon pump in this very sick group of patients with shock post-revascularization is thought to be because of the result. The intra-aortic balloon pump has gotten out of favor both in the European and the ACC-AHA guidelines as the ideal support in this environment. What we can be specific for the left ventricle, the right ventricle, both ventricles, and obviously, as you know, in the COVID era or in the influenza with ARDS for pulmonary support. Interventionists in the peri-STEMI setting as they perform revascularization or to support the ventricle following revascularization with the goal of preventing end-organ hypoperfusion and damage. You see on the left something that is available quite universally around the world, ECMO device, which can easily be put by the bedside or in a procedure room by accessing the groin and doing a fem-fem. Use a tandem heart where you see the cannula is in the left atrium having gone across the interatrial septum, and the left ventricle is decompressed in this fashion with an oximeter and a pump pushing the blood. In the United States is the impeller, and I'll talk about that a little later in the course of this talk. And finally, we still have these bulky surgical interventions to support the ventricle, like a sentry mat, vary from hardly any unloading with an ECMO. In fact, these ventricles are not unloaded. They have to push the blood against a significant afterload to complete unloading when we really want it by using based on the configuration with which we use these devices. What has really changed now is our ability to also perform specific right ventricular support. And so here I've shown you take blood from the right ventricle and pump it into the PA. This works really well, but currently is placed through the groin. There is a one coming through the neck, but as a result, the patient has to be lying down. We could certainly do a tandem in an RVAD configuration using two catheters in the proximal and right atrium and the distal PA. We often use the Protect Duo, which is a single in this setting. This is the impact that these devices have had and continue to have in the United States in the setting of shock. You can see that, but we do not use it when the main issue is lack of cardiac output. In parallel, you can also and tandem heart are increasing dramatically over this past decade, and these devices continue to be used in an increasing manner in our patient population in the CICU. Myocardial infarction with adjunctive revascularization. We use an impeller device, which is very easily placed retrograde across the aortic valve. It comes in different sizes, and I've given you the relative trend. But what has really translated for us is that we have now often converted to an auxiliary impeller in a setting where we think the support is going to be prolonged. We have warranted. Now, the impeller is clearly causing decompression of the left ventricle. As a result, you can see on this very nice physiological finding, it actually markedly reduced acute myocardial infarction. A large randomized trial by Naveen Kapoor is going on in this setting. But with the impeller device, we can decompress the left ventricle and get favorable hemodynamics in the setting in cardiac workload, while also helping with end-organ perfusion. This is what I spoke about in my earlier slide. When we think the support is going to be prolonged, we often go in with and with this, we can provide long-term decompression and support of the periphery. And this may be our go-to device very often as we transition support and we bridge people to a decision of durable VAD or even transplantation. The tandem, often it requires going across the interatrial septum in a very, very sick patient who is having an acute MI and in shock. So it can be clinically quite challenging. But given how good our structural interventionists are now, this has over the past few years as we've evolved with the impeller, but certainly a device to consider in this setting. The ECMO we tend to use when we need emergent biventricular support and this florid cardiovascular collapse in the setting of an acute myocardial infarction setting, which is not the talk for today. We may use central cannulation, but this femoral cannulation approach with these beautiful small ECMO support devices now, which we can even use to transport patients, number of contraindications to ECMO support, and I will not highlight them in this slide, but clearly I do think that prior to putting ECMO, it really needs to be a patient where you are reasonably confident. Now, one of the issues with ECMO support that has always been a concern is that given the fact that the support is retrograde through the aorta, the left ventricle, which is already challenged by an acute myocardial infarction, is now faced with very significant afterload, and so the impact of significant afterload causing lack of decompression of the ventricle, as very, very nicely shown on this slide. What this on the left highlights is that at least in the poor quality, but studies that have been done, a device to prevent the complication I just described, and that then leads to various combinations. And here you can see one of the easier combinations is to put an ECMO device along with an intra-aortic balloon pump. But sometimes you put an impeller first because you're decompressing the left ventricle. It's quite common in our CICUs to support the ventricle. And so here are examples of biventricular support configurations, either using an impeller RP or a Protect Duo to support the right ventricle, decompressing the left ventricle, and you can get biventricular support in this to buy you time in this setting. Let's put this all together as we end this lecture. I'm going to put a very, very simple case here so that it doesn't confuse. Elevated JVD, blood pressure in the 40s in the setting of what looks like an RCA infarction. You can see here the right coronary artery is proximally completely occluded and highly thrombotic. But in the interim, the patient is hypotensive and would go into ATN and extreme liver failure in this setting. So instead, we decide to support the ventricle. This patient is quite hypoxic too. You can see on the echo, there's an RV that's dilated and dysfunctional. The LV is fluids and dobutamine, and hope for the best in this situation. But in this case, we ended up placing a RP impeller device. I don't have the thing for me, but in a couple of days, the right ventricle completely recovered with an RP impeller, and then we hospital. When patients have a STEMI or any other form of shock, our team is contacted through this number. It instantly gives people access to a team that consists of a critical care intensivist in the CCU, a heart failure transplant cardiologist, an interventionist, and a heart failure surgeon. And together we identify the. This is our support in the setting of high-risk STEMI. I hope you enjoyed this talk. I look forward to seeing many of you in person in the years to come. And thank you once again for.
Svenu, I think that was a great talk, and I think we need a reality check as to what is feasible in our own country. You did mention that the IABP uses come down, and you talk. This is the only go-to device that we have in the cath lab, or before we get a patient to the cath lab. Is all the data on IABP as bad as the shock trial, or is there? I've seen some meta-analysis which have shown,
We continue to use the intra-aortic balloon pump as our main device in the unit, But I think the idea is, what are your goals? So clearly, for someone who's ischemic, for someone who's got a ventricular septal rupture, I think the IABP is a nice first device to go to. But when the issue, IABP can only do so much. And I think in that kind of setting, you probably need to go on to other devices. But I think the IABP, unlike the guidelines, we use it all the time in the unit. So you shouldn't feel bad about not having other devices with you. We think it's a terrific device. And I am very concerned about the patients who are in shock after doing a PCI, 50% with cardiac arrest. And that's not the patients you're putting an IABP in. Most of the time, you're putting an IABP in someone who's got refractory ongoing ischemia, these advanced devices, because the IABP just cannot do what you can. But you certainly should continue to use the IABP, because I think it has a tremendous role, and we see its benefits every day by the bedside.
Thanks, Venu. I think that was really reassuring for many of us.
I think the key is early initiation. That is the key. I think if you put it early, then it may be yes. So I think
Comments
we can
from
move on.
others on the panel to.
And they're in shock. Do we try to go for the artery first, or we put the balloon pump, or what do people think in terms of timing and strategy around that?
I think balloon first.
I think I would agree with Shireesh. This is our philosophy in the emergency room. We might put the balloon pump as we're getting the patient ready, and then shift it
first, and PCI soon after.
Any other comments? Thank you, Venu. That was great.
Thomas, I think you all should build and I know Impella is expensive, but you all should build.
That's the way forward. I mean, I think it's not rocket science. It can be done. I'm sure it can be done.
But I know we're late, but I think, what these devices have done is they've completely changed our CCU. So now my CCU is full of people on support right now, but, I think it's not a priority right now.
In fact, here at Ohio State, Ramesh Amani, one of my colleagues, is a heart failure attending, board certified in heart failure, went back and did a year of intervention to do intervention heart failure, purely to provide
where to go from there. So I think that's something, again, you need to play God at some point there and say, okay, I need to pull this out, and that's going to be a much harder decision for all of us.
So Thomas, who of course requires no introduction at all. With Ajit, I think he has been Survey Sarva of STEMI India and has been doing a fantastic job over the last 7 to 8 years.
MI in Indians, and look at what are the difference in presentation, pathology, and management with insights from the TN STEMI program. Now, if you were to look at the incidence, and this is data from across the world, you'd see that most studies talk about 4 to, we've taken 45 years as a limit. Now, on the other hand, if you look at the TN STEMI program and look at the data, you will see that 24% of our patients, out of close to 2,400 patients that we had in the TN STEMI program, were young MIs or less than 45 years. Of patients in India who are young MIs. And I think it's important to look whether the risk factors and the management have to be different for this subset of patients. If you look at males, 27% are young MIs, while in women, it's not the role that female hormones play on STEMI and coronary artery disease. What are the risk factors? When we classically talk about young MI, we talk about the atheromatous coronary heart disease with typical risk factors. Primary among them are cigarette smoking, positive family history for premature coronary artery disease, lipid abnormality like congenital coronary artery anomalies, and those are less common in our population. And of course, the hypercoagulable states, antiphospholipid antibodies, SLE, nephrotic syndrome, and the contraceptive pill use, especially when young women present with MI. And often it's not just one or hypertension. You can see less than 45, there is a significantly lower incidence of diabetes and hypertension. But if you look at active smoking, 61% of those below 45 years were smokers 45. So it's really premature hypertension, premature diabetes, which seems to be risk factors in females. And while in males, both diabetes and hypertension are less common, but smoking seems to be the major risk factors. What about the clinical presentation? I think it's important to fully evolved MI occurs in these patients. So they generally don't have angina over a period of time that then presenting to you with an MI. And the duration of symptoms is usually very short. And look for stigmata of dyslipidemia, primarily familial dyslipidemia. What about mortality? And I think this is important. Again, these data that is again from the TN STEMI program is very similar to the data that you would get from across the world. For the less than 45 compared to 15% for those above 45 years old. If you look at gender-wise, again, you'll see this huge difference in males, 2.9 versus 5.4 in hospital. In hospital, they're not very different in women, though there is a considerable difference when you look at 1-year mortality. Now, interestingly, if you look at 1-year mortality in the young women, it's 50% considerably higher mortality among women, but that I think is another issue that we need to talk about. When you look at the reduced mortality, one of the questions that is often asked is, are these patients presenting much earlier? What is, if you take the males and you look at it, it's 180 minutes, it's about the same for those above 45 years. So there's really not much of a difference. And if you look at women, 230 versus 210, so women tend to compare to the hubs. And this is not unusual because young women presenting with chest pain, often you don't take too much notice. I mean, the family doesn't take too much notice. And when you go to a hospital with chest pain, very often the doctors think that this is non-cardiac chest pain. And I think that could be part of the various series which looked at what is responsible for MI in young patients. And what they saw was that if you were to look at multiple patients with, this is autopsy of ACS patients, and if you look at younger patients, you will see that in MI, if you were to take the patient to a cath lab, you could see plaque ruptures, you could see erosions with thrombus, and it could be due to calcific nodules in a small proportion of patients. And this is some of the data, this is from Rajani, is a major mechanism in young patients who present with MI. So what are the challenges in managing ACS patients by plaque erosion? And the erosion study really showed that it is possible in many of these patients if you treat them with a thrombolytic or with thrombus aspiration and leaving them without stenting, and you could get a fairly good result with similar MACE at 1 year. Cap and looked at 9-month mortality to show that they're very similar, whether they're stented or not stented. However, that's not the end of the story. I think when there is a plaque erosion, often in the Western population, the data presents that they present converted not into non-STEMIs, but into STEMIs. And for this to happen, I think you need a thrombotic milieu. And this has been shown in multiple studies from India. And this is a study from Sri Chitra, significantly higher in the younger populations who presented with young MI. So there is this hypothesis that today, many of the young MI patients, the risk factors are mainly smoking or binge drinking, proteinopathy, or any of these fibrinogen, increased fibrinogen or 83. These patients will present with a thrombotic occlusion and therefore will present with STEMI, but the management may have to be different because the thrombotic load may be much higher. I'm just looking again at the TN STEMI program. You're aware of this. And we looked at the various treatment modalities and looked at mortalities. This is 1 year mortality. And if you looked at below 40 invasive management. If you look at primary PCI, it's 3.6% for less than 45, 8.5 for primary PCI. However, if you looked at standalone thrombolysis, you can see that the mortality is very high, 21% for MI population. So what it tells us is that a large percentage of the young MI patients who we now postulate have fairly high thrombotic occlusions. Standalone thrombolysis may not be a bad option in these patients and may give you a reason to do primary PCI. Know that when you have a 30-year-old person who comes with an MI and his only risk factors are smoking or heavy alcohol or binge drinking, you know that they're going to have a huge thrombus load and you need to work with the thrombus. Slow flow is much more common. They present more, not have angina, pre-existing angina or subtotal occlusions or lesions. They present with acute occlusions, which are usually thrombotic, and therefore the infarctions are much larger. Many of them could have coronary ectasia, and the challenges of STEMI in hepatic vessels, I think, is something a whole topic in it before one decides to leave it alone. Because if you have a plaque erosion, if you have a plaque rupture, then leaving it without stenting may not be a very smart thing to do. So the question of use of stents in this situation is important. Studies that compare the newer lytics in younger and older age groups. Intracoronary lytics might work. Thrombosuction alone may work. Avoid stenting if you are certain that it's a plaque erosion and it's mainly thrombus, and if you've been able to remove the thrombus, then it might be smarter. Intracoronary thrombolysis, intracoronary or intralesional abciximab, or deferred stenting. I think these are options that one might consider when there is very large thrombus leak. Secondary prevention, I think, is critical in these patients because they're young, they have a long lifetime associated risk factors of hypertension, diabetes, managing them, or familial hypercholesterolemia. So to conclude, young MI accounts for 20 to 25% of STEMI in India. Cigarette smoking is the most common and most modifiable risk factor in multiple studies from India. Diabetes mellitus and hypertension appear to be less common in young male patients with coronary artery disease than in young female and older patients. Other prothrombotic risk factors are common and need to be evaluated, and often it's angina. And in the majority of cases, an acute coronary syndrome that progresses rapidly to MI is the first manifestation of coronary heart disease in them. The mechanism of MI in these patients may be more often may yield greater light on this. Management of STEMI in the young is different to that in older individuals and the typical Western population. Aggressive secondary prevention is mandatory. Thank you.
That was an excellent talk, Thomas. One of the common risk factors that we come across is actually a non-traditional risk factor, and that is work-related risk factor. So work stress has become a very important risk factor for young infarcts, at least. Other panelists, any comments, anything? Is it that common in the US compared to India?
Thomas, outstanding talk. And my thoughts, clopidogrel at the same time, right off the bat. What are your thoughts on that, given it's so thrombotic?
You said Plavix and clopidogrel.
I'm aspirin and clopidogrel.
Okay. Yeah, I think so. Maybe. See, I think all of us who practice acute MI, cases here in India, I think to take this guy because, for the next 1 hour, 1.5 hours, you're going to struggle with the thrombus in his coronary. And you wish to hell that, he was in some peripheral hospital where they thrombolized and then shifted him, where, at least part of the thrombus is gone rather than used. Yeah, I think any
Thomas?
Yeah.
Thomas, can you hear me?
Yes, Ram.
Yeah. You are given a very nice picture about the pathogenesis mechanism and the management of young patients in our places. We are seeing this is a very important talk in India because we see even youngest patients compared to the other part of the globe. And actually, these younger patients we have seen many times already with the full of evolved Q waves and other things, compared to the older. When the old patient goes, immediately first thing they think of myocardial infarction. When the young patient goes, is a lost thing. So that's what we always come across. What is the picture in the other part of the world? Do they have?
Venu,
I'm sure we have similar problems. I think we see less younger group of patients. I think the system, if you come in with a chest pain syndrome, you will get an younger women where we see SCAD and MINOCA and other mechanisms of myocardial infarction. I think the one thing, especially in the South Asian population, at least in the research data, and there's some light there, is, the relationship of Lp(a) and early premature disease has been pretty strong in most data sets and associations. And I think right now we have for the first time ongoing clinical trials that can reduce Lp(a) dramatically. And it will be interesting to see if these drugs are successful, quite strong.
One of the favorite theories that I have, and again, we talk about ACS that in South Asians, that in Indians, about 60% present as STEMI as compared to about 35 to 40%. Now, what I feel is that 60-65 that present as non-STEMI in the West, this difference of 60% and 35% is, and that's my hypothesis.
So, for the folks, what is the data in India about air pollution and smoke we have about ambient air? Have there been very good studies in India done by ICMR and other organizations about this risk?
Okay, Venu, let me just give you one bit of information. During the lockdown, 40 days prior to this and 40 days during the lockdown, we had a 40-day lockdown. We correlated that with young MI. I mean, we looked at the demographics. MIs as a group were less, and that was because of access and whatever else that was in the 40 days preceding that. We looked at the pollution board data to look at what are the pollution levels, and there's a dramatic drop in PM2.5 and PM5, particle size in the atmosphere during cigarette smoking. Shops were closed. Alcohol shops were closed, and the youngsters in India traditionally do not smoke at home. They smoke outside. And when you have a lockdown and you're stuck to your house, related, maybe all these played a major part in the young MI, where lifestyle is the major reason. And, the older population, where it's the traditional risk factors, continue to show the same MIs, but the young. Okay, I think we go to the last talk for the day, for the night. Umesh Khot was here yesterday and spoke to us yesterday. Today, Umesh, can we have Umesh's slide up there? Chairman of the Department of Cardiovascular Medicine at the Cleveland Clinic. Umesh.
Thank you very much for the opportunity to speak to you today on managing mechanical complications in ST elevation myocardial infarction, timing and the key mechanical complications in ST elevation myocardial infarction include free wall rupture or pseudoaneurysm, ventricular septal rupture, papillary muscle rupture, and something that's been diagnosed more lately. We start talking about free wall rupture and pseudoaneurysm. The key facts of this is that the incidence of this has been decreasing, about 1% of ST elevation myocardial infarction. It typically occurs early in the first 24 hours. It has been shown to reduce the risk of rupture. Typically, this is associated with large transmural infarction. The presentation from a clinical standpoint is hemopericardium, tamponade, syncope, and sudden death. A picture of a patient with a syncope and a free wall rupture while in the echo lab. And if you look here at the top, you see the baseline echocardiogram. And then you see here the rupture here at the bottom with the person suddenly with pseudoaneurysm here at the bottom part of the picture. And so what you can see here is a substantial change in the blood flow pattern here, and a significant amount of the blood flow is now extending into the pseudoaneurysm, leading to shock, syncope, almost twice the size of the left ventricle. And so these can be substantially large, leading to catastrophic outcomes. Look at the size here. This is almost 7.6 by 10.4 centimeters. Cardiocentesis. And ultimately, the only effective treatment for this is surgical repair. Surgical repair is associated with a very high surgical mortality. But if the patient does survive surgery, the long-term survival overall is good. Myocardial infarction often involve disease in the left anterior descending artery. There's a decreasing incidence with lytic and PCI reperfusion. And this condition actually has a very high mortality, 40 to 80%. In fact, it is probably the cardiogenic shock and hypotension, new holosystolic murmur, or right heart failure. Here's an example of a ventricular septal rupture. You can see here the gap in the myocardium with a subcardiogram that shows that septal defect there. And then you can see on color flow, significant blood flow that's crossing from the left ventricle into the right ventricle through the ventricular septal rupture. Management of this in anatomy. The timing of surgery in this condition is very controversial. There are concerns that if you go to surgery too early, the ability to put this together may be difficult, while at the same time, if you wait too long, the patient may have a thoracic surgeon database, almost a 50% operative mortality. But medical management in this condition is futile. Here's a general framework for a management strategy. And if you look on the ECMO to support them and ultimately delay surgery. If they're stable hemodynamically, you can sometimes watch them with atrial reduction or mechanical support and delay surgery. And if they're hemodynamically stable, in the delay elective surgery or percutaneous closure. From a surgical standpoint, these are the two basic ways in which this is repaired. One is called the Daggett repair, which is a patch. And the second thing is a David repair, where you can percutaneously close this. Here you can see a VSD on angiography with contrast in the right ventricle. You can cross the VSD, and then you can snare across it and put a device to close the VSD. Ruptured papillary muscle. This typically occurs 2 to 7 days post myocardial infarction. It typically involves a posterior medial muscle greater than the anterior medial muscle because of single blood supply from the right coronary artery. The extent, if the patient has a delayed presentation of STEMI, this is more likely. And the myocardial infarction here may often be small and is often not catastrophic in some of the other cases, as you've seen earlier. Patients here present with cardiogenic shock and hypotension. If the amount of blood flow going across the left ventricle or left atrium is so large, there may actually be a very brief murmur or no murmur at all. You can see rapid left ventricle and left atrial pressure equalization, and on right an echocardiogram showing severe torrential mitral regurgitation on transthoracic echo. And you can see here more closely, you can see the mobile papillary muscle with a flail mitral valve leaflet. Case that there's a partial rupture of papillary muscle, which can clearly be seen on transesophageal echocardiogram and can be easier than transthoracic. Here's an anatomic picture here of what happens when you see complete rupture of the papillary muscle. The mitral valve doesn't function at all, and you have massive mitral regurgitation. The role here is to stabilize with nitroprusside and intra-aortic balloon pump, surgical repair and replacement. Again, these conditions have a high mortality at the same time. The fourth complication is something that's been described here more lately, particularly with widespread utilization of echocardiography in the critical care setting, and it's called acute LV outflow tract obstruction. Other than STEMI, it can occur in stress cardiomyopathy or Takotsubo. It can also be iatrogenic in certain patients if they're put on inotropic agents. This is the pathophysiology, and you can see here the transitory basal hypercontractility. And then if you have a condition that worsens this, either by using inotropes such as dopamine or dobutamine, you can then get worsening obstruction leading to hypotension, and this cycle continues from that standpoint. Actually worsen this by trying to support it with dopamine or dobutamine, and you can get into a downward spiral of profound shock, which really needs to have a reversal of strategy to improve it. So the presentation here as cardiogenic shock and hypotension is that if you have hypotension that is unresponsive or worsening with inotropes or balloon pump or afterload reduction or vasodilators, then you really should be concerned about this finding, because typically most conditions improve with this. And so this is a cardinal clinical. Here's a picture here. What you can see here is you have large area of anteroapical akinesis from a large left anterior descending artery infarction. And you can see a hyperdynamic base. And then you see systolic anterior motion, leading to difficulty for blood to leave the ventricle. The treatment for this actually is to stop any inotropic or support agents and attempt obstruction from the systolic anterior motion of the mitral valve. The management of this is cardiac catheterization and revascularization to improve the apical akinesis. Intravenous fluids are important, and you want to cautiously start administering beta blocker to control the heart rate, particularly if they're tachycardic. In summary, mechanical complications of myocardial infarction have a very high rate of mortality and done immediately. Many of these patients need medical stabilization through a variety of techniques, but ultimately many require revascularization and definite surgical therapy. Thank you very much for the opportunity to speak to you about these.
Thanks, Umesh. I think you highlighted the clinical conditions that we need to keep a watch on when patient presents with shock, and especially in the smaller centers where you may not have. From me, Umesh, often what we see in our practice is a late presenter who's had a VSD or a VSR comes to us a week later. And these are the sort of patients who do well. Patients have already died, and the ones that come to you, and this is probably the one of the advantages of the late presentation that we see. You know, a lot of patients present with MI a few days later. Or
there have been multiple reports that all of these complications are going up, and there have been multiple case series from a number of centers, US, internationally, Italy, showing a large increase in these things. So I think that's interesting is that some of this issue in terms of selection bias in your case, I think is true, but any patient who has a ventricular septal rupture, it just, the protoplasm of that patient, I think, is different than other patients. These patients tend to be often frail and elderly. Go in there, what type of muscle that they have to repair, and there's a lot of times when they have breakdown as they're trying to suture it. And so I think even though they may be stable in late presentation, it's still, until they get them through, it's always
being thrombolized and developing cardiac rupture. We know that that's a risk factor, but we've been seeing them in the COVID times. Patients presenting late, you don't want to take them to the lab, you thrombolize them, and suddenly...
The timing of surgery for VSR is controversial, but what is a generalized guideline? What is a convention? What is being followed at your place? What is the time?
I'll have, Venu can talk a little bit more directly about on that.
Thanks, Umesh. So I think we certainly, the issue with waiting is that you can get sudden hemodynamic instability. So in most cases, as soon as we die, if we feel that the defect is just so destructive, where there's dissection of the interventricular septum and a really good surgeon cannot repair it, then we would go on to supportive therapy and buy ourselves time. So high that even with a great surgeon, it can't be repaired. So we'll go into the OR with a backup plan for transplantation in the back, especially if it's a younger patient. But I must say that over the years, just like Umesh, we have tended to be a little more conservative this past few years and allowed them to be monitored and go and operate in day 7 or day 8. The percutaneous option for us has not been very successful. That's been our backup strategy when we just cannot do surgery. And I must say also, the location of the infarct plays a pretty big role, because clearly if it's an apical LAD infarct, to do an infarctectomy and it's functional, that even in very good hands does not survive surgery. And so in those cases, we tend to buy support with some supportive device like ECMO or tandem heart. One of these things we use much more often now than before. Advice I would give Tom is that, in this day and age, the people in the emergency room are so used to using upfront dual antiplatelet therapy for an acute coronary syndrome, especially when that benefit is a rupture, before giving them dual antiplatelet treatment. Because, it's a hard enough situation with the best surgeon in hand. You give dual antiplatelet treatment on top of that, a hard situation becomes with an MI. And if you hear a murmur or if you suspect a tall JVD, don't give dual antiplatelet therapy before identifying that there is not a myocardial complication.
I think there's a question from...
I think, I'm being biased because we are in a very, very great surgical center with outstanding surgeons. But I think that it's a very reasonable question to ask, because with primary PCI, the rates of 1980s and 1990s who saw it every day, even the average surgeon in the United States does not see a ventricular septal rupture. So you really need to have the right surgeon for it. And I can see a lot of surgeons with some mechanical support and buying yourself time may convince some of these risk-averse surgeons to operate on these patients.
Actually, I must say that we have a fantastic surgeon. We do at least one rupture repair of the patient through, I think.
And that's especially true for papillary muscle rupture. I mean, if you go in there and you replace the valve and you decompress the lungs, these guys are going to do superbly well over time. So there's no reason not to.
Of a great 2 days of, has Ajit rejoined us? I think he
Thomas, can I make a comment before you conclude?
Yes, please. No, yes, of course, Ramakrishnan.
On behalf of the speakers, chairperson, thank the organizers, Dr. Thomas, Dr. Rajesh, Dr. Shireesh, Ranganath, and the whole team behind the screen. Really, it's a nice program we have witnessed. Congratulations to all of you. Thanks a lot.
Okay, so it's expanding across geographies in India and abroad. One of the newer initiatives that we have now decided on is to look at private clusters and involve private hospitals. And this is because our aim has always been to work with government to improve access, especially among the BPL population, to STEMI management. But we now believe that we need to expand our area who have a significant amount of work in the STEMI area. And if you're looking at setting up a STEMI system of care in your geography, do reach out to us, and we'd be happy to help to set up a program faculty, but especially for the foreign faculty. I think you guys have been great, taken time off. All of you have been so busy. And Bernard Gersh, Jagat Narula, Raghavendra Baliga, Christoph Naber, helped us in formulating many of the plans that we have done in terms of the STEMI work that we've done. We've bounced ideas of you, written papers with you. You've been a resource, a STEMI program forward, and in really encouraging us in everything that we've done. Thank you so much. Thank you for being with us. We're really, really grateful. We hope that in the coming year, when we are bringing your expertise to the doctors who practice in India. Let me also take this opportunity to thank the sponsors. I think 3 companies, Sun Pharma, and USV Gold Partners. We are really grateful for the partnership that STEMI India has had with you. For the conference, we've had sponsors. I'd like to thank the platinum sponsors first. AstraZeneca, Boston. Thank you very much. Without your sponsorship, I think it would not have been possible for us to run this meeting. I must also thank Promax HD Events from Nagpur, Sameed Mardikar and Shruti Deshpande, and managed to get this whole program going. Thank you very much. We're really grateful to you. And last but not least, all the participants who spent time here today. I hope it's been a Shireesh, Ajit, your last final words before we close.
Yeah, we really had a wonderful time, and I hope that everybody else also, all the participants, had a wonderful time. And thank you. So maybe, hopefully, next year, we'll have a physical conference.
Yeah, I think hopefully I'm just trying to get Ajit also on the line to join us. Okay, on behalf of Ajit, Shireesh, myself, thank you very much. Thank you, everyone. And we hope we will meet again next year without a pandemic and to spoil the great camaraderie.